to note that for those who are able to stay after the seminar, as usual, we are providing refreshments, drinks, wine, juices, and nibbles in the foyer. And secondly, I'd like to mention some future events in, next year, as mentioned on the slide. I will send you, probably on the mailing list, notifications when we're meeting these close to the events. So our next seminar is on the 6th of March, and that is with Professor Anne-Marie Nelson from Cardiff. And she'll present some interesting new research that she's undertaken with the team in Cardiff, exploring why different stakeholders' perspectives, exploring their different perspectives in the last 30 years days of life, do so many small cell lung cancer patients receive anti-cancer therapy. And then on the 12th of June, we are going to have our birthday event. So our department, Marie Curie Cancer Care Research Fund, has been around since the summer of 1999. And we invite you via the mailing list to come and celebrate with us. And we have a theme of our research and improving the quality of care for people with terminal illness and the people who care for them. So I'd now like, it's my privilege to warmly welcome to you the centre of our autumn seminar, which is Mike Bennett. And he is Sir James Professor of Palliative Medicine and the Director of Academic Unit of Palliative Care at the University of Leeds. She has made an outstanding contribution to palliative medicine. His main interests are in pain management and advanced disease and in diabetes, decision-making and intervention midwifery. And also, I'd just like to say, Mike will speak for 40 to 45 minutes, allowing us between 15 and 20 minutes for questions.
Thank you, Bridget. And thanks to the Marie Curie department here for inviting me down to speak with you. It's a great pleasure to come down. And thank you for turning up on a really cold Wednesday evening after work, after a busy day at work. So I hope I can make it interesting for you in terms of something you can learn about pain management interventions delivered in the community. So as Bridget says, I'm a consultant in palliative medicine. I work 2 days a week in a hospice. I do mainly outpatient domiciliary work. So I know if the community services are anything like in London as they are in Leeds, it can sometimes work really well, but sometimes it can be very chaotic, fragmented, continuity of care is a challenge. So I'm very much involved in sort of clinical delivery as well as the academic side. So to begin, I want to introduce you to Bob. He's a guy in his early 80s. He's got a colon cancer. He's got bone metastases. He knows he's going to die from his disease at some point in the future. We don't know when. The PIP study might tell us at some point when that's going to happen. But he's contemplating the end of his life. And Bob, like many other people in his situation, is concerned about a number of things as his health deteriorates, but principally amongst those is whether he'll get more pain or whether his pain will get worse. And he's not alone. This BMA study, published a couple of years ago now, interviewed about 500 or so patients and their patients, the members of the public, as well as a similar number of doctors. And you can see that the commonest concern in terms of the height of the bubble for the patient or the public was pain. That's the main concern when facing end of life and dying, followed closely by a whole range of other things like the impact on loved ones leaving family and so on. But actually the same concern around pain management or pain relief was shared by their doctors as well. So when doctors were asked about what concerns you most about patients who are dying, then a slow and painful death, particularly in a hospital, were the sorts of things that came out from the doctors' perspectives. And really that's justified, particularly in cancer patients, but actually the prevalence of pain in non-cancer patients is broadly similar. So in this country, in the UK, about 160,000 people a year die from cancer. About 2/3 of those patients will experience pain. So it's also worth noting that about 1/3 of patients who have cancer or who die of cancer don't really experience significant pain at all. However, for those that do, about half will experience moderate to severe intensity pain at some point, and about a third of cancer patients that die from their disease are probably undertreated in relation to the severity of their pain when compared to the strength of analgesic prescribing that they receive. So Bob's a bit concerned because he's seen these kind of figures. He knows that pain is quite common. He knows that there's a good chance of undertreatment, possibly. So he's concerned about what you or I, as a clinician or as a practitioner, might do to help him in his pain management. So I'm going to focus on what interventions improve the experience of pain in patients approaching the end of life. So if we went to a medical school or looked at a nursing textbook possibly, most sort of healthcare professionals are taught this sort of concept of pain management, that there's a peripheral nociceptive stimulus, like a burn or a jab or something like a big lump of cancer eroding into tissues, causing inflammation, maybe some nerve damage, neuropathic pain. So all these nociceptive stimuli in the periphery travel up to the brain, where pain is experienced, sort of hurting pain. And this linear sort of relationship can be measured quite simply by asking the patient on a 0 to 10 scale, how severe is your pain? Is it 8 out of 10, that's severe? Is it sort of 4 or 5, that's sort of modest? Or is it under 3 out of 10, which we would all be relieved that that's more like mild pain? So there's very, very linear relationship between some peripheral insult, lump of cancer, the experience of pain, and directly translated into a numerical intensity score. That's a common sort of concept of pain that many clinicians are taught or have, certainly. But what really happens is this. So nociception or peripheral pain stimulus is important in part of that experience of pain, but so too are a number of other things, including a patient's lack of understanding about their pain, what's the cause of it, how might they manage it. They don't know how to manage their medicines. They're faced with a whole barrage of different analgesic drugs, perhaps. They don't know how to manage those. Patients may have poor coping strategies when faced with quite a sort of a big life event. They may have low expectations of getting better, or low expectations of their symptoms getting better. For many patients, for many people, pain is an inevitable part of dying. The healthcare system in which they live or are may be poorly responsive. It may take them a while to get a GP appointment. They may not get an out-of-hours visit for 6 hours or more if their pain is out of control. Their GP surgery may say to them, well, it takes 48 hours to process a repeat prescription, so if you've run out, tough luck. You come back in 2 days' time and you can have your refill of your opioids. The chemist may be shut on a Tuesday afternoon, where they want to cash their prescriptions. So all these things about the health system can work against patients experiencing good pain control. And so there are a number of other things as well, but if you add all those up, that's what colours the patient's or the person's experience of pain. All these things factor in. And the way to measure then the sum of all that is not on a 0 to 10 rating scale, but instead to look at how that pain experience is impacting on daily living for that patient. So are they able to manage this idea of self-efficacy? Can they cope? And what impact does it have on the daily activities that they want to do? Are they able to dress themselves, move about, walk, drive, work even? And that's reflected in these sorts of studies, qualitative studies of patients with cancer pain. So this one by Jacqueline Bender is quite interesting because it was really revealing when patients are asked, what do you want to know about your cancer pain? These are the sorts of things that commonly came up as themes. So simply to have an explanation of what's the cause of the pain, knowing what to expect in terms of the pain. Is it likely to get better, worse? What are the options for pain control? Patients can choose then which ones would work for them best. How might somebody cope with their cancer pain? What strategies, drug or non-drug strategies, would work for that person? Maybe finding help, so the idea of supporting patients to manage themselves. So how can patients find help to manage pain? And perhaps some simple help in describing their pain, or how can you maybe communicate pain to healthcare professionals? This is another study from Bristol, from Karen Forbes' group, where patients were asked, well, what might you expect about your pain? management. And what was interesting is that patients expressed ideally that they'd like to be pain-free, of course, but actually most said that they didn't realistically think they'd be pain-free, but actually what they wanted was better pain control. Asked about numerical rating scales, universally patients didn't find them helpful in expressing their experience. And actually what came across was that patients judged whether their pain was under good control, not on a numerical scale, but actually whether they were able to do the sorts of things that they wanted to do, whether their function was maintained, tailored to what function meant for that person. And this is one part of a series of studies we've been doing in Leeds, doing longitudinal interviews, seeing how patients manage with their cancer pain. And what we find is that patients constantly make trade-offs between these sort of three areas in the balance. So you might think as professionals, the view is, right, stamp out pain at any cost, so we just ramp up the analgesia until pain is gone. But actually what patients do is they try and balance up the cognitive effects of analgesia, so the drowsiness, dizziness you get with pregabalin, some tiredness in the afternoons with opioids possibly. Those cognitive effects of analgesics are balanced against physical activity and pain. So a patient may actually prioritise physical activity above everything else, in which case they'll trade off greater pain or poorer pain control in order to have less analgesia and fewer cognitive side effects. Other patients may actually say, I want my pain to go at any cost. I'm quite happy to have a settee day, lying on a settee all day. I don't mind being a bit more drowsy or tired, so long as the pain is not bothering me as much. But that can change on a day-to-day basis, depending on what the patient's needs are. So there's constant trade-off on a daily basis. And so the literature around concordance with analgesia is kind of rife with stories of concordance rates of 50%, 60%, so whatever we as clinicians think patients are taking, it's not always as consistent as that. And that's part of it is, I think, this trading off that patients are managing themselves as to what works best for them. So let's turn to some important interventions that I think are probably most useful for people with cancer pain or any pain towards the end of life. There's a good I think it's a good summary in this editorial that I refer you to in detail, which I'm not going to cover, but I'll just highlight some of the main things that I think want to take home messages. So if we look at Bob's bone pain, that's the thing that's causing his pain. There's all sorts of interesting and weird mechanisms from translational science that we've learned about, and that's happening inside his bone that's eroding. So sensitized bone nociceptors, some injured sensory nerves, there's a mixture of inflammation, some central sensitization, a bit like neuropathic pain, all these sorts of mechanisms. And there's a big industry looking at different targeted drugs for these different sort of molecular mechanisms. That's all well and good. But actually, when you look at what are the most effective interventions for someone like Bob, who has cancer-induced bone pain, we published this review a couple of years ago, and we were trying to calculate the NNT values. That's the number needs to treat, which is it's a crude measure of effectiveness across different interventions. So, and very roughly, it's a number needs to treat of 2 would mean that if you take 2 patients and you treated them with a strong opioid, at least one would get a meaningful response over and above that achieved by a placebo alone. So it's a measure of effectiveness. So the lower the number needs to treat, the better or more effective is the intervention. So you can see immediately that the best things that Bob needs for his bone pain are probably a good dollop of opioids if it's quite severe, and some radiotherapy. Now he may get offered a bisphosphonate, not a bad thing to have perhaps. He may also get offered some fast-acting fentanyl, but actually that's not as effective or any more effective than probably a dollop of Oramorph or a placebo sometimes. So that's the least effective intervention. So strong opioids and radiotherapy will be the strongest evidence supports these interventions. So in terms of strong opioids, nice guidance published 6 years ago now around opioids. And as part of that review process around the different opioids, the commonly used opioids, the sort of buprenorphine, fentanyl patches, oxycodone, morphine, a bunch of others. A lot of meta-analyses were undertaken. This is one example that compares, in the bottom part of this table, compares morphine versus oxycodone, shown that there's absolutely no difference in efficacy between oxycodone and morphine, to the surprise of some clinicians, or many clinicians possibly. And in fact, that's true for all opioids. So there are no differences in efficacy between the patches, morphine, oxycodone, at a group level. Clearly, at an individual level, some people may get on with morphine and not fentanyl. Others can't smell morphine before they go dizzy, whereas they're absolutely fine on oxycodone. But at a group level, there's absolutely no difference in efficacy between all the strong opioids. Broadly, there are no differences in CNS side effects between all the strong opioids. So no opioid is cleaner or better or less sedating than another opioid of that group. The only difference, significant and important difference, is that patches are less constipating. That's the only major kind of difference in side effects. That's all you need to know, I think, about strong opioids. So, strong opioids, take your pick, they're all good stuff. So we've got, we know that opioids are efficacious. We know in a country like Britain and many other Western countries that opioids are freely and easily available in terms of for therapeutics, in contrast to many countries in the world where actually opioid access is pretty awful. It's very difficult to get hold of opioids. Bureaucratic bureaucracy and regulations get in the way. So what's the evidence from countries like Britain or Canada, as this paper's from, about opioid access? So this is an interesting study of 40 or 50,000 patients that died from cancer in Canada. It was a while ago now, about 15 years ago. And the authors examined the trajectories of opioid prescribing in the last year of life for all these 50,000 patients. And this is what they found. I haven't got a pointer, but let's have a look at the finger. So what you can see is that so this is death. Here is week 0, and then all the way from about a year out. And what you can see is that the commonest trajectory is trajectory 0. The thick grey line goes along the bottom here, representing 58 to 59% of patients. That means 59% of patients that died in Canada in those years never got a strong opioid before they died. The next commonest trajectory is trajectory number 1, representing about 15% of patients, showing that opioids were prescribed in the last 8 weeks, the last 4 weeks of life, sometimes the last couple of weeks of life. And then trajectory 2, a little bit earlier, about 3 or 4 months before death. But that actually accounts for, what's that, 60, 75, or 85% of all opioid prescribing happened either people never got an opioid, or if they did, it was in the last couple of months of life. That's only 15 years ago in Canada. So we repeated that in the UK, or in Leeds anyway, in this paper. So we linked opioid prescribing, cancer registry data, places of death, and so on. And we found a very similar sort of picture. So the first thing to note is that only 48% of patients who died from cancer ever got a strong opioid prescribed before they died. Which that shocks some oncologists. Everybody dying of cancer is either, death of the eyeball with morphine, by all this palliative care lot. But actually, many people don't actually ever get access, don't get an opioid before they die. And you can see that even this is 6,000 patients. This represents. And you can see that even at 6 weeks before death, only 30% of patients that go on to die of cancer have ever had a strong opioid prescribed. Now, the median duration of opioid prescribing is about 9 weeks. So many people are just getting their opioids. Many people dying of cancer are only getting their opioids in the last few weeks of life. And you can see that that sort of graph increases in the last sort of 4 weeks of life. So that's when the majority of opioid prescribing takes place. So we've got an efficacious intervention, strong opioids, NNT of 2 for most people. And yet the problem for many people with cancer, they're not getting access to that early. When you look at when people are experiencing pain, it's much earlier than the last kind of few weeks of life. So the problem remains about access to opioids, even in this country. Now, for someone like Bob, it's a worse story, because those are averages across all people with cancer, and of course many people with cancer are over the age of 65. But for someone like Bob, this is our analysis of age-related access to opioids. You can see that compared to early versus late access to opioids, we just did that around see that for someone like Bob, he's probably 2 to 3 times less likely to get an early access, or 2 to 3 times more likely to get late access to an opioid because of his age. And this age gradient is very clear in opioids and in some other graphs I'll show you in a bit. So the older you are as a cancer patient, you're even less likely to get early access, and you're far more likely to get later access, perhaps in the last 2 or 3 weeks of life rather than the last 6 or 8 or 10 weeks of life. So age is against you as a cancer patient. Now, one of the government policies about improving access to opioids has been non-medical prescribing. So in 2012, the rules changed for non-medical prescribers, allowing allowing scheduled drugs to be prescribed by independent non-medical prescribers. So in this study we looked at what might have been the impact of non-medical prescribing in palliative care, particularly around opioid access and pain control. So it's a bit difficult. What we did is we asked the NHS Digital, as it is now, can we have all the FP10s prescribed in the community that have certain drugs that we thought indicated a palliative care prescriber, because what you can't find in these databases is Joe Blogg's palliative care prescriber. So we looked for prescriptions or prescribers that had issued prescriptions for midazolam, levomethasone, hyoscine, diamorphine, things like that. We identified those, and then we found out what other prescribing that person was doing, and we identified those as palliative care prescribers, doctors, nurses, pharmacists. And then we looked at the number of prescriptions that they were responsible for. So in this chart, in this graph, you can see that between 2011 and 2012, the first year we looked at, there were just over 1 million palliative care prescriptions issued in the community. And actually that's increased up until 4 years ago now, 2014-15, about 1.6 million prescriptions issued in palliative care. You can see that nurse prescriptions, so nurse non-medical prescribers, have almost doubled in that amount of time. So actually there's much higher activity in non-medical nurse prescribing. That's great. But when you look at the proportion of their prescribing against all palliative care prescriptions, it's still relatively tiny. And we, at the rate of growth, we did a sort of back of an envelope projection of it. It's going to take 20 more years or 25 years before there's going to be any significant impact in relation to non-medical nurse prescribing against all palliative care prescribing. But one of the things we did find was for non-medical or nurse prescribers in particular, the main activity in their growth between those 4 years has been in bullying the opioid line, not in any other kind of drugs. So actually non-medical nurse prescribers are very active in opioid prescribing. So actually that's a good indicator that early access or better access to an opioid may be helped by community nurse prescribers. What we also know is that what this data doesn't show is that all the other things that nurse prescribers do, de-prescribe, cajole GPs into prescribing more accurately and better, and all these sorts of things, it isn't captured by this. So the effect of nurse prescribers is broader than this, but it just illustrates that actually better access in the community to opioids, non-medical prescribing may be an important vehicle for this. So, in this paper, we looked at the evidence that accessing palliative care might be another vehicle for improving access to an opioid. And the focus of the paper was looking at where did people die when they've been involved in palliative care, and can we look at the odds or the increased odds for every extra week or so of palliative care? What difference does that make for end-of-life care outcomes? So I'm just going to show you the opioids data. So these are the odds ratio for getting access to an opioid in the last year of life. If you've never received palliative care, if you die without getting into this palliative care, your odds are this red dot over here, so that you're far less likely to get an opioid. If you have a very short amount of time in palliative care, those are your odds there. The black dot, that's the reference dot. And then for every additional sort of clump of weeks of palliative care, your odds of getting access to an opioid increase. And that's actually quite similar for odds of dying at home, avoiding hospital, avoiding emergency department in the last few weeks of life, and the other outcome was this is Anne-Marie Nelson's story about avoiding chemotherapy in the last month of life also. So there's almost like a dose-response relationship. We can only show associations in this. But for the more palliative care that you get, or an argument for earlier referral to palliative care, the greater the odds are of getting access or having better outcomes, including access to an opioid. So, opioids are really effective, but the problem is poor access in the UK, even in today's world. What about other drugs used in pain management? Well, I'm not going to spend any more slides talking about drugs apart from this one, which is a study we did, or a meta-analysis looking at the effect of adding an adjuvant like pregabalin, gabapentin, amitriptyline, everyone's favourites, to an opioid for poorly controlled cancer pain. And what we found is this: low quality studies, few in number, but there's no good evidence that actually adding an adjuvant makes any difference to the pain control compared to a placebo when someone's already on a strong opioid. Now, that is depressing, isn't it? Let's face it. But it also tells us that what happens in these studies, and you can see that each of the individual studies were negative as well, so it's not just the overall meta-analysis, but the individual studies were largely negative. And what happens in these studies and in the meta-analysis is that people in the intervention arm, the ones that got the combination of adjuvant and opioids, they experience far more side effects, more drowsiness, tiredness and so on, than people on opioids alone. So it is true that people who don't respond adequately to an opioid, they may need an opioid switch, they may need some other interventions that may be non-drug interventions. But what is true, I think, is indiscriminately adding in adjuvants and piling in more analgesia often makes people worse rather than better, or it's a very finely balanced line. So it's just to be cautious when you're combining these things. So, and here's my other summary, just to get the depressing news over. So opioids are most effective by a country mile, but as I say, the problem is access to a prescription and a prescriber, which is often late. Radiotherapy is pretty good for localized bone pain. NSAIDs are probably helpful, but paracetamol definitely isn't. There's no good studies showing efficacy of paracetamol when someone's already on an opioid, so forget paracetamol. I think there's a meta-analysis showing steroids are worth a shot, but very modest effects, and adjuvants, the burdens may outweigh benefits. So for the person who was concerned about the paracetamol, there is a meta-analysis and a few studies about paracetamol in low back pain, acute pains. They're not that helpful, and the evidence in cancer pain supports that as well, or is consistent with that. So, what else can we do? Well, let's look at some behavioural or sort of non-drug mechanisms that may be helpful for patients. And going back to that sort of diagram, or the way I see sort of cancer pain, all the other influences, what patients want to know, and all the other influences on the pain experience, I think that's where the clues are as to how we might improve the pain experience for people, not just the nociceptive pathways, which is what everybody concentrates on. So here's a summary of evidence-based interventions, evidence being either greater satisfaction or trial evidence suggesting better outcomes. But generally, if you pay attention to a patient, they enjoy that. So increased patience, if you're a bit nodding off, a bit disinterested, a bit disengaged, that's a poor outcome. If you're engaged, asking people questions, attention, that's an important aspect of professional behaviour. If a doctor states the importance of pain control in a consultation, that's associated with significant benefits compared to not. So by that, I might say either ask someone about their pain, if it was an oncology consultation, or if it's something like in a palliative care consultation, just stating that it's important to get your pain better. Let's sort of think about how we can tackle this, taking things like seriously. That's associated with better outcomes. If a patient receives instructions on how to manage their pain at home, that's associated with significantly better outcomes. And that could be simply, this is what you do with your Oromorph, this is your slow-release medicine. If you're in trouble, this is the number to ring and who to contact. Don't do this if this happens. Some simple instructions all helps. If fears about addiction or other side effects are addressed, that's important, so you're not going to become a vegetable by taking this morphine. However, you might experience some tiredness in the first few days. This is what to do if you've experienced it and to look out for. So explaining side effects, the constipation, so on, that's all very helpful. Can pain assessment, just simply routine pain assessment help? Well, this is a meta-analysis of studies that recorded or measured pain as part of a systematic collection of pain assessment using consultations. So the good news is that it's a helpful thing to do. The disappointing news is that it has a very modest effect. So here, this diamond is on the right side of the line, or the correct side for benefit, but it reduces your pain score by just under 1 point, or about 0.6 on a 0 to 10 scale. So that's a very sort of small, modest kind of effect, really. But one of the things the authors comment on in this paper is the low fidelity. So an example might be an oncology outpatient service where patients fill in questionnaires or a touch screen symptom check when they turn up for the oncology visit. But the fidelity, so not everyone's filling them in, not everyone's using that data in the consultations, the fidelity is low sometimes in these pain assessments. But when it goes well, it can work well. It can have a better effect. Oops, wrong way. So one thing to do is simply assess patients' pain systematically and mention that in the consultation. These are evidence-based behaviours that result in improved pain outcomes. Another thing that clinicians or prescribers can do is actually stick to the rules or stick to guidelines. Here's two randomised trials that compared, doing the same things basically. They compared clinicians that were asked to stick with a prescribing protocol or local guidelines around cancer pain management, or others that were allowed to do what they wanted. So in this study, the clinicians followed the algorithm. There was some support from nurses, and that actually might be an effective intervention in itself. Nurses followed up and checked for side effects, and the intervention group compared to the control group got an additional 1 point drop in their pain score, which is a reasonable effect. Exactly the same sort of thing here, but instead patients were, as well as the clinicians following the prescribing algorithm, patients were given an explanation on opioids and common fears, and that group did a lot better sticking with the prescribing guidelines than the control group. So, sticking with guidelines, mentioning pain and assessing pain, they're all effective behaviours. Relieving patients' pain with expectation intervention. This is quite interesting. This has nothing to do with cancer pain, but it just shows you the power of attention and having a confident or realistic outlook rather than being it's going to be terrible, we can't get you, there's no other drugs that work, and we can't do anything. So this meta-analysis, this is an example of the sort of expectation cue. So the agent you've been given is known to powerfully reduce pain in some patients. And so some modification of that might be, well, some patients get on really well and find this strategy helps their bone pain. Let's see how it works for you. And actually, it's quite a powerful effect. So a medium effect size in healthcare interventions is quite something. And so just raising expectations of better outcomes has an important effect on patients' pain experience. What about interventions to patients? So we focused on clinicians' behaviour, so making someone like me assess someone's pain properly, stick to prescribing guidelines, explaining side effects of things to patients. All these things are very helpful interventions. Interventions to patients. So here's a systematic or a meta-analysis of, they're called educational interventions. They're probably, a better term might be supported self-management or helping patients manage themselves. So this is providing information to patients about their medicines in particular and their pain, some strategies or some ideas for managing out of hours, for example, what to do if there's a pain flare-up, these sorts of coaching or helpful information things for patients. Here's some of the components. So explaining the cause of pain and promoted self-management, addressing fears about opioids, often usually face-to-face coaching sessions, or maybe just a written leaflet like in that previous trial. And how effective are these? Well, they're relatively effective. So in this, the average pain intensity in this meta-analysis was reduced by just over 1 point, and worst pain intensity sort of similar. Now you might think, well, how big is 1 point that's important? Opioids, in this kind of comparison, opioids would probably reduce pain scores compared to placebo by about 2 points. Gabapentin, effective gabapentin, about half a point. Additional benefit possibly in some trials. Paracetamol even less than that. So actually some of these interventions are more powerful and more effective than drug interventions, and yet they're probably underused or they're not recognised as interventions that can improve patients' pain experience. So helping or supporting patients to manage themselves, you might think is a labour-intensive, no one's got time for that. But actually a single dose or a single or low-intensity dose or a written leaflet, a one-off consultation for 5 or 10 minutes can be as effective or is just as effective in this evaluation than frequent, high-intensity coaching, a series of 8 meetings, daily coaching for a week. No more effective than a one-off intervention, it seems. So actually brief interventions work and are good enough. Yeah. And when you combine a few of these interventions together, like in this trial, you get some interesting idea of whether these things can work as a whole. So in this trial, this was depression and pain, but in the pain arm, the intervention consisted of some medication management, so that was a sort of a clinician sticking to guidelines. They had some automated symptom monitoring, so patients there was interactive voice recognition on the phone, so it got phoned up by a computer, punched in their pain score, and then clicked off. So automated symptom monitoring, if the score was high, the nurses or the doctors got alerted. And then the nurses did some sort of phone support, checking symptoms, side effects, altering their analgesia. So that sort of supported that complex intervention proved to be quite effective. So this is over a 12-month follow-up. This is in America. So they recruited oncology patients, and you can see that there was an early difference emerging, sustained up to about a year, about a 1-point difference. So all that effort, you think, for 1-point difference. And you think, well, what other service might that look like? So medication management, symptom monitoring, check, a bit of supported self-management, nurse checking, looks like palliative care to me. So let's think about, well, what effect does palliative care have, or palliative care services have on people's pain? Well, disappointingly, a couple of meta-analyses aren't that helpful. So this is probably the best one, I think, is from JAMA, shows that involvement in palliative care or earlier palliative care from these kind of trials of early palliative care showed a small but modest or improvement in quality of life, no clear benefit on symptoms at all, and no effect on survival. So broadly similar is this Cochrane review about the effectiveness of home-based palliative care services. Showed increased odds of dying at home, a reduced symptom burden but very small effects, nothing specific about pain, and inconclusive cost effectiveness. And it's important because actually not only is pain one of the most feared problems that people facing end of life are worried about, as I showed you in the first slide, but these data from the Voices questionnaire, the NHS bereavement survey that's been running for 5 years, it's stopped now unfortunately. But this shows people's perception, or the surviving relatives' perception of their loved ones' pain experience in the last few months of life. And what you can see is that this is by place of death. So the dark blue represents pain that's relieved completely all the time. The orange is some of the time, red partially, and then sort of blue not at all. And you can see that actually hospices are pretty good places to die in relation to good pain relief experience. Hospitals aren't bad, or they get sort of slagged off. Actually, the worst place to be for experiencing good pain control is at home, actually. And this is every year the Voices data shows this, that pain experience at home is the worst compared to other care settings. But we've been analysing, and we've got hold of all 110,000 responses from the NHS bereavement survey now. We've got all the ethnicity and all the. It's taken us a while to get hold of everything. But we've been looking at what difference does access to palliative care make for people at home in particular. So we can try to go into the data and find who's accessed a Marie Curie nurse, Macmillan, had a hospice visit, or some other connection that would be a proxy for palliative care access. And the first thing that we found was that people with cancer, this is for people at home only, so 21,000 people at home with cancer, about 2/3 of them had access to palliative care, fine, but actually only 10% of non-cancer patients get access to palliative care, so that's a big sort of problem to start with. Those who made an advanced care plan, much more for cancer, but still relatively low in terms of advanced wishes, planning ahead, coordination, and so on. And that's a problem because in terms of earlier access to palliative care for both cancer and non-cancer, so we looked at when do people get access to palliative care. And we found that this is a survey of 200 hospices in the UK, about 65 census returns. We have data on about 43,000 patients. We found out that people in this country are getting referred on a median 48 days before death to palliative care services. About 40% of all patients that receive palliative care in the UK are referred within 30 days of death. Staggering, isn't it? Someone like Bob, he's at a disadvantage, so he's less likely to get a long duration of palliative care. He gets the shortest amount of palliative care compared to people who are under 50. And then cancer patients get twice as much palliative care duration compared to non-cancer patients. And not only is the access different for cancer versus non-cancer, but the duration of palliative care is different as well between cancer and non-cancer. So let's go back to the NHS, so the bereavement survey. So what difference does having access to palliative care make in terms of your pain control if you're at home? Well, the good news is it makes a lot of difference. So this is the divided by cancer and non-cancer, and you can see that if you have access to palliative care, in the green bars, your experience of pain control increases substantially, whether you've got cancer or non-cancer. So being referred to palliative care at home improves pain control, or is associated with improvements in pain control. So these are the odds ratios, about 2.5 times better chance of pain control. So to summarise that bit, intervention or community interventions around assessing pain, stating the expectations of pain relief, supported self-management, providing information for patients, all those things improve a pain experience. And actually when you bundle some of these things together, and we might call that palliative care access, you can see that even in the UK data there's good evidence of an association between better pain outcomes and access to palliative care very clearly. But the same issues are with opioids access. So we know that opioids and palliative care are a good thing, but the problem is accessing opioids happens very late, and accessing palliative care happens very late in this country as well. So 48 days median contact time with palliative care is quite short, isn't it? So we were ambitious, and this is a program grant that's just finished called Impact that I was leading. This is ended up in, we developed lots of interventions for patients, looked at pharmacy interventions. We ran a randomised controlled trial. We recruited 160 patients, 80 in the intervention arm, which consisted of sort of early referral from oncology outpatients, some electronic pain reporting system, and self-management support for patients. The pain monitoring system is called Pain Check. Patients could dial in, go on the web from their home. They were connected to their community CNS, who could respond back, send alerts. So it was an early warning system for symptom monitoring for pain. The reason we did this trial, because we know from the data that people are getting referred about 7 weeks before death to palliative care, that they're probably getting pain going wrong much earlier. This kind of data shows in terms of symptoms and function. And pain has been, this is other longitudinal data showing pain, which is in blue here, is relatively prevalent for most of the last 6 months of life, not in the last few weeks of life. So we know that people experience pain for a lot earlier than the last few weeks of life. We developed this Tackling Cancer Pain book. That was a sort of self-management intervention. So we asked the CNSs to go through that with patients, explain, and there's DVDs about relaxation, all the strategies that patients can use that might help themselves. What was interesting was that we found we recruited patients, well, it turns out a median of about a year before they died. So they were ready, they could benefit from palliative care at least a year before their death, whereas normally in practice they're only getting referred about 7 weeks before death. There was no difference between the arms in this study. But unfortunately, there was no difference either in the outcomes. So there was no additional benefit from the self-management support or the symptom monitoring. That said, the symptom monitoring the fidelity was extremely low, so only about 30% or fewer patients actually engaged in the symptom monitoring. If the nurses were less convinced, let's say, about the symptom monitoring, then often the patients took the cue that they didn't bother with that either. So there was low fidelity amongst these interventions, unfortunately. So there was no difference between the groups. But what is interesting, I think, is these are cancer patients who wouldn't have ordinarily been referred, but only were because we screened and we found their pain scores. You can see the average pain scores, or worst pain scores were 8. Average pain scores, these patients were 6 out of 10. That's average pain scores, quite high. These are patients a year before their death, and they entered into the trial, and they got a significant benefit. Both arms got a significant benefit in terms of reduction in pain, and yet they wouldn't have been referred for palliative care support had we not sort of screened or identified them in practice. But we've got lots to learn from this. And that's pain interference. So what does this all mean then? So in the final slide, so what interventions are most effective for people, particularly in the community? Well, if we look at physiological interventions, opioids are very effective. So I've tried to compare the effectiveness, well, not quite on a pain intensity scale, but on the money to treat. So opioids are an effective intervention, stand out amongst all the other analgesic interventions. Adjuvant NNT is probably greater than 10 and not that effective, unfortunately, despite what we think. Behavioural interventions are probably more useful. So after opioids, think about what else can you do for your patient or their carer in terms of supporting them and helping them manage. So assessing pain systematically, sticking to prescribing protocol, that's an effective intervention or effective behaviour for us as clinicians. Helping patients support themselves or helping carers support themselves, that's another study we've been doing, is an effective intervention. So giving them strategies, knowing what to do with the medicines and how to get help, other ways of moving around and so on. So supporting self-management is an effective intervention. When we bundle some of these things together, we can see in trials that there can be a 1-point difference in some of the American trial and other trials. And actually from data set analysis, we can see in routine data that referral to palliative care services, we can calculate the number needed to treat for improved pain relief, that's about 4. That's still reasonably effective. So referral to palliative care is an effective intervention and accessing, or is an effective intervention for pain management. But as I say, the problems for both of these are that we've got effective intervention, it's just that many people are accessed very late. So the opioid access is quite late, and the access to palliative care is unfortunately very late. Worse so if you've got a non-cancer disease. So, what can we do for Bob? Well, I think sometimes, rather than remember everything that you have to do or everything that's efficacious, just pick one of these things and do it, and that's probably doing Bob a favour. So I would do, so if you see him, you might state the expectations of good pain control, give him some information to support himself, assess his pain, focus outcomes on maintaining Bob's function rather than saying that you're going to get your pain relieved at all costs. So it's what does he need to be able to function? Identifying physiological mechanisms. Does he need an opioid? Stick to guidelines. Review Bob's pain. Is he experiencing side effects that need to be managed or titrated? Offer some sort of nurse or pharmacist phone support. That's an effective way of keeping people going. And ensure your service can respond if Bob has severe pain. Thanks very much indeed.
Thanks, Mike. It's brilliant. Really entertaining. How do you respond? I noticed you published a few things in the MJ open, underlining the fact that opioids are prescribed perhaps not as frequently as they could be. How do you respond to the BMJ's campaign about opioid crisis?
Yep.
Opioid overprescription?
Yeah. So I think there are two sort of currents at odds here. So one is the there are two public health crises, let's say, or public health challenges. One is that for people who aren't dying, they're on long-term opioids, which reduces the quality of life, and opioid diversion or misuse can lead to deaths. So that's the kind of the opioid crisis, that, particularly in North America, where there's huge amounts of opioid misuse. Although some of the data shows that actually it's not the patients who've been prescribed the drugs that are dying, it's their relatives or others who are taking the drugs from them and misusing them. However, it's a big public health problem. So it's much harder to get access to prescribed opioids in the United States now than it used to be some years ago. And there is certainly a prevailing view, correctly, perhaps, in this country that actually low-dose short-term opioids are probably helpful for some people with chronic pain, but long-term high-dose opioids are unhelpful or aren't associated with the improvements in quality of life and actually can cause harms in terms of immune function, hormonal function, and so on. But I think there's baby in the bathwater here as well. So what has always been a problem, what has always been correct is that people facing advanced disease or dying in pain can benefit substantially from opioids, but the problem is late access. And I think the challenge is particularly with shipment in this country as well. It's a while ago now, but I think people are still wary of it. And it's almost like any excuse not to prescribe opioids is what people will latch onto, or to delay doing that for all sorts of reasons. But nevertheless, I think the epidemiological data about pain and pain severity doesn't match that with a prescribing trajectory, which is still occurring very late for cancer pain. So I think the way around this is actually, if you've got someone with advanced disease, who clearly, with cancer or non-cancer, who's clearly not going to be cured or get better from this, but actually assessing their pain, looking at managing their pain effectively, and that may include opioids, is an important part of that. But yeah, it's a problem in terms of particularly people that are not skilled at opioids, so generalists rather than specialists is a problem there.
In your study, I saw that the mean pain scores are the same in both, and they came down in both in the interventional and the usual care. So what happened in usual care?
Usual care got palliative care, so both arms got palliative care. So they were, I didn't make that clear. So in both arms, what we tried to do was to screen patients in oncology, and the original protocol was early referral to palliative care, enhanced palliative care in the community with all these interventions, versus usual care in oncology. As soon as we started screening, and we found lots of people with pain, the oncologist said you can't go into a randomised trial being allocated to usual care, you have to be referred to palliative care. So we couldn't recruit anybody to the trial. So instead we said, well, let's make this trial a bit more attractive. So we offered both arms access to palliative care, but the intervention arm was enhanced sort of support in the community. Yeah. So I didn't make that clear. So in some ways, we knew that it would reduce the chance of finding an important difference between the arms, but it still might be useful. But also we discovered implementing interventions in community services is hard as well in terms of fidelity. So that was a challenge.
And I was interested in your comments about the TNS, what the sort of team needed.
So there's things. So I think there's, in terms of things like support yourself, I think the first thing to say is that often some of these things, we develop these interventions based on what we thought was good practice happening in palliative care anyway. But then sometimes, some people were embracing this electronic digital engagement stuff, and others were really not at all. So that was one thing. I think the one positive from the trial is that we recruited people, we found people a year before they were going to die who were eligible for palliative care. We haven't shown the data, but at the end of the trial, many of those patients stayed in palliative care because of ongoing needs, and everybody got an important benefit to their pain. So it's a good, if nothing else, it's a good argument for earlier integration with palliative care. You don't need to remain in palliative care, but you can benefit from some early interventions by palliative care.
I completely agree with your comments about paracetamol and
Yeah.
it's a huge tablet burden as well.
Yeah.
And I spend half my life crossing
Keep prescribing,
paracetamol. But I just wondered whether there's any evidence or whether any other person in the room has had experience about the use of intravenous paracetamol.
Oh, yeah.
Because, oh my goodness, the patients love it and it seems to make a difference. I just wondered what you think about that.
Well, I think it was in Bern. I think somebody was telling me about intravenous paracetamol, and I think the first thing, my response is, let's get a trial done. Really, because of all these things, it sounds great, and it may well be there's something about it. Who knows? But all the paraphernalia about injections, attention, it's an important, serious thing. That can make a big difference clearly. So it's trying to separate that out from a clinical effect, but that's right for a nice clinical trial.
Yeah, I work in acute pain. We use IV paracetamol and trying to. The standard has become intravenous paracoxib, intravenous paracetamol, and who just reminds us that somebody can take something, but not they should take something. It's cheapest, when you consider the cost when it first came out. I was the first person in the whole of the 4 countries to get IV paracetamol on formula. It was £10, 17 a dose, which was actually 5p more expensive than a gram rectally. But in fact, there's no evidence in acute pain that there's any difference in efficacy. What we do notice is much shorter onset of action, but also shorter duration of action.
Okay, that's helpful.
I think we're on time now.
Great. Well, I'm sorry if I've overrun.
So thank you very much.
But I'm around outside. I think there's some things that I'm very willing to have a chat in, but if you were able to stay. Thanks for your attention.